Hello, everyone. My name is Logan Halick, and I will be presenting my capstone case. I come from the Whistleblowers of America agency, and this will be a presentation that will have two sections, one on the capstone case and one a reflective piece on human diversity, social justice, ethics, and social policy. So with that, I will begin with my abstract. The presentation is going to follow a client that I had from the WOA. It's going to be split into three separate subgroups that include biopsychosocial assessment, intervention, and evaluation. The content will contain all the pieces of a proper case from beginning to end. This particular client wasn't a correct fit with the WA agency, but I did the most I could with the tools and resources available to me to treat the client the best I could under the circumstances. And I try to give him the best possible care from a humanistic perspective. However, my strategies and interventions I used proved to be ineffective as a result. The client removed himself from my care with no intention of coming back. While this case may look like a failure, another perspective can view it as a testament to resiliency, boundaries, and agency capacity, which I will go over towards the end of the case. So case introduction. To start off, instead of referring to him as the client, I'm probably going to refer to him as Jared. He is a 38-year-old male. He is Indian. He's from Arizona. He's educated. He's bilingual, speaks English and Hindi. And he is variable socioeconomic status ranging from low to middle class. His reason for referral was he needed help. He needed resources to help him and spread the truth of the situation occurring over the last 2 years he's been experiencing. He went through normal channels to become a client and receive an intake. And for the biopsychosocial part of this subsection, for the engagement process, he submitted a request through the WOA. These details about his case are usually involved in there, but he didn't want to disclose that and preferred speaking with someone directly about it. My supervisor assigned me this case, and I scheduled a meeting with Jared for an interview, and then I proceeded to schedule an intake after the interview was done. So during this, I established rapport with Jared. I met with him virtually, used meaningful body language to display safety and comfort. And I observed Jared's body language in turn, like the background of the room he was meeting in, as well. Jared had some problems speaking, but he was able to explain his thoughts, feelings, and story. He seemed closed off, scared, and made very little eye contact for engagement. He provided key details of his case while assuring that it was hard to believe it was true. He was doubtful that I believed the story and details about it that he shared. This ultimately made him upset, and he did not want to engage with me for a little bit, for a few minutes. But I relied on assurance and understanding to bring Jared to engage with me again because it was a critical moment in the engagement biopsychosocial piece, and bad rapport can hurt the client retention rate according to Mercantile. Jared felt heard again, and then he continued to engage with me for the rest of the intake. For demographic information, 30-year-old Indian male was born in America as a second generation. He lives alone and has cut off ties with his family. He is bilingual. English is his primary language, and Hindi is his second language. The presenting problem for coming to us at WOA was he was facing retaliation from his prior university and federal government branches, including the NSA and CIA. He claims there have been numerous attempts on his life, and government operatives are either trying to murder him or break him to the point where he commits suicide. So the history of this dates back to 2023, where he made a breakthrough discovery regarding AI. He was at university finishing his master's degree in AI engineering. He had an intern placement at the CIA. He claimed that they sabotaged him, made all of his coursework and credit hours moot, and they changed the degree requirements for his master program that only he was a part of, as he was at the university and ultimately did not graduate. During this time, his supervisor at the CIA quit his job to teach a class at the university, but he believes he only did so as a ruse in order to spy on him and keep tabs. All these retaliation factors caused him not to graduate, and he was shunned by all of his professors in the university. And all the affiliates with him as he tried to talk to him to try to recoup some of his losses. Then in 2024, CIA operatives moved next door to him and started toying with him by messing with all of his electronic devices remotely while pretending to be his friend and getting information regarding his research in AI and what he knew about it. He said that they poisoned him and multiple other attempts were taken on his life by them. He claimed him and his family and close circle of friends have been drugged, and he referred to MK Ultra as a way of a psyop on him, that they were trying to, get him to commit suicide or tell him things that he wouldn't normally disclose. Um, this was resulted in him moving to a different part of Arizona where he made another breakthrough discovery in archaeology, and because of that, the CIA and the NSA pressed harder and have not let him up since the present day of the intake. So for psychiatric history, he's received counseling services, but never stayed for long, as he believes the government is the one that's giving him counseling services. In 2024, he saw five different psychiatrists, and they all said that he was mentally sound and doesn't need to be seen by a specialist or take medication, despite his circle of support telling him that he needs to be seen. He has no significant medical industry history besides when he was, a kid going to the hospital for just, things like a cold. Um, he's never used recreational drugs for his substance abuse history until 2024, where those CIA agents gave him benzodiazepines, hallucinogens, and drank alcohol. But he realized that what they were trying to do with the MK Ultra, and he ultimately stopped. Um, Personal and psychological history. He comes from an educated family. His father's a biologist, his mother's a pharmacist, and had many professional degrees. He said he had a pleasant childhood and grew up in an upper middle class lifestyle. As a career, he was a day trader and helped other people trade stocks until 2020 when he became interested in AI and went to university to pursue AI studies. He's never been married but date a lot. Doesn't have children, has a very small family, only speaks with his parents and his family, other than and doesn't speak with any of his other relatives in India. He's spiritual, loosely, believes in Buddhism, but he claims it's not a significant part of his life. Um, He's currently self-isolating, doesn't go outside or speak with other people out of fear. During 2023, 2025, he suspected he had society and depression. Otherwise, he claims he's been mentally stable his whole life. For the examination, Jared was alert and oriented. He knew where he was, who he was, the date and time, had no irregular patterns to indicate otherwise. He was dressed appropriately for our meetings, but did not appear to be groomed. He had a look of exhaustion on him. Speech was fast, upbeat, and sporadic, especially on tangents and strayed away from the topic of conversation. But while he was on topic, he was organized in his thought processes. But his insight and judgment did not seem to be based on reality at the time of speaking. He was deeply disturbed that he was scared for his life on a day-to-day basis. So for scales and instruments, standard for WA, we use the PHQ-9 and the GAD-7 in order to scale where they're at in forms of anxiety and depression. And he did score pretty high on these tools. And for the problem list, the identified problems were self-isolating, obsessed with online interaction, extreme moments of distress, fears for safety on a mental basis, constantly being watched, paranoia, extreme delusions, psychotic tendencies, seemingly no circle of support currently at the time, and difficulty trusting anything and anyone. And for case interventions, so after the end, so what he wanted to do was stop the government retaliation and murder plots. I couldn't really fulfill those goals because I had no affiliation with him, and he wanted like military involvement, other branch involvement, but I couldn't really help him with that. My supervisor was in the CIA, and when I brought this to her, she was like, there's no way we can like confirm or do anything about this. And it's like very, very unlikely anything like this has happened to him or anyone else. So instead, we try to look for common factors within our therapeutic relationship, and transition from presenting problem and the external threats to manageable internal symptoms like managing paranoia, reducing social isolation. Jared set a firm boundary, refusing psychiatric services, maintaining he's mentally sound. So I prioritize current progress over forcing a psychiatric goal, so I could preserve the therapeutic alliance. So the objectives, working on self-isolation by engaging with friends and family. I asked him to try to reach out to a person from his small circle of support at least once per week to start. And then technology management, he's hyper focused on, AI and computers and spent most of his time on the internet at all hours of the day, talking like maybe 14 to 15 hours. So I tried to, ask if, 6 hours was manageable. I didn't want to go any lower than that because that would just be kind of, impossible goal. So I tried something a little bit more manageable, and he said that that was something he could work with. And that I said we'd, tweak it based on, how he was doing in future sessions. Um, Social boundary settings. He appeared on a lot of podcasts talking about his experiences and his breakthrough in AI and mathematics. I urged him to try to stop appearing on this because the facilitators of these podcasts were mainly making fun of him and exasperizing, what was going on with him and kind of, we're just calling him crazy. And he was the joke, but he didn't really care because he wanted the information out. But we both kind of identified that this wasn't healthy, so we went with that as an objective. Um, so we went with M. Barkham's framework, objectives giving a balance to behavioral changes, that'd be limiting the screen times, calling friends or family, with cognitive exploration by addressing the logic behind his paranoia. So for strategies and interventions, we looked at CBT and ACT. So cognitive restructuring, role play, and thought experiments for CBT, while ACT, diffusion and values clarification. For the CBT, wanted to kind of not outwardly challenge his delusions, but like kind of challenge his thoughts that may be leading to them. For the ACT, trying to find that self-worth and autonomy so maybe he can feel, comfortable in his own skin again. So with that being said, going CBT and ACT is a dual path approach, but I just wanted to kind of see what stuck better and then focus on one and go with that. But I didn't really know how to tackle this as he was my first client that was kind of going through an active psychosis. So it was a very dynamic treatment that where the interventions would be changed based on the outcomes, from session to session. And the evidence-based context, for my strategy was that, having those heavy internet uses would be exacerbating his anxiety and related disorders. This was brought up by Ding. So for evaluations, this case, so measures I used was client self-reporting, and direct clinician observation. So I wanted to get firsthand data on Jared's internal experiences and the effectiveness of the interventions from his perspective. And, we track his paranoias and adherence to the goals and objectives that we made. And for the clinical observation, seeing those behavioral changes, physical cues, and progress that he may not explicitly verbalize. And the application, of course, would be doing the face-to-face session virtually, and talking about these in supervision meetings, how they went and kind of tweaking the treatment from there. So, I collected these measures for every client interaction I had with Jared. So every session I was, note taking. Yeah, and then I went to my supervisor about my observed data. For the evaluation design, it was biweekly sessions, which is pretty standard with the agency. Followed the established clinical practice of the agency, documenting and monitoring with follow-up strategies. The intervention model was CBT, what we went with, but and then also narrative therapy as well. For his internal and behavioral objectives, and I incorporated some psychoeducation to help the client understand some mechanisms behind his symptoms. But he did not like this part of the design. He really did not perceive this well. He perceived it as a threat and a non-belief that his paranoia, it's, confirming his paranoia and that I was out to harm him. So it was very invalidating for him, and it really damaged the therapeutic alliance, long and short term. So the indicators of the decline from the design is, disorganized thoughts, emotional dysregulation, and clinical determination. Based on his psychotic episodes, his mental state was, worsening, and it shifted the interventions from, having that as some of the focus to something else, mainly just him, kind of letting off steam or telling me what's going on with him rather than doing any kind of treatment, at all. Um, and so the final assessment of the design efficacy was the evaluative measurements from the direct observation. And the role play was definitely unsuccessful because every time we talked about what would it be like to, talk to one of the people that are performing the psyops on him, which would be like the CIA or NSA agents, it was too surreal for him, and the paranoia and the it was just, bleeding out, and it was too uncomfortable for him, and it really was just not a good intervention for him because it was too much for him to handle. So we ended up stopping that. Um, so so he had deterioration, he had worsening symptoms, he had a physical decline, from observing him, he lacked in self-care, he was getting increasingly pale and groomed, and his living environment became more cluttered and unkept. The target goals were not met, and the client eventually walked out of the final session and ceased all contact with the agency. So it was pretty much a treatment failure. So the self-report data, the negative feedback loop that we used, as the session progressed, Jared's self-disclosures moved from a desire for help to expressing that I was not helping unless I could get someone else involved and that I was pretty much useless otherwise. So that was like, the military, other branches of the government, anyone else. He had a dissatisfaction, and I could tell from an upward trend in negative statements regarding both the process, the therapeutic process, and his own mental state. This is just a very simple, brief graph from each session of his own self-report statements that I had written down in my notes that I could put together in a quantitative piece. So as you can see, as the sessions went on, it never got better. It only got worse. And by, the fifth one, we got to 10, the session wasn't even done. He walked out early. So it could have been more than that if he stayed, but it was clear that the treatment was not working. So, misalignment of intent, there was a conflict between his goal, like our goals. We made goals together, but his goals were really, to get help outside. I believe he may thought talking to me would help him get there, but that ended up not being the case, and I think that frustration led to him leaving. He was in, a pure state of psychosis, having psychotic episodes. He was unmedicated. He's never had anything like this before, he claimed. So, he's never seen anybody about this other than those psychiatrists that said he was sound the whole time. So the CBT and narrative therapy was mostly ineffective. We barely got any work done or any kind of positive progress. And the level of care, it just was not appropriate for the whistleblowers of America to have this case. His case fell outside of our scope of the outpatient care we do. He didn't even meet the criterion for whistleblowing and retaliation against your job. But my supervisor wanted me to have this case anyway, so it just wasn't the right place for him. And I think that caused mental anguish because we kept him, but he wasn't getting what he wanted. So for my recommendations, for the final as the result and evaluation of this, I would like to see him be an inpatient and like in a high acuity inpatient care with administration of psychotropic medications. I feel like that could really help him, maybe ground him a little bit more, maybe see that he's having very delusional thoughts. The rapport limitations. A different approach might have fostered better trust, but I did the best with what I could and the resources I had and the person that I was as a therapist. And he just did not need that. He needed a political entity to fight on his behalf. And I could not provide that. It was outside of my scope and ability. So for my conclusion for this case, it was extremely difficult, but I maintained professional standards through consistent supervision and consultation. I prioritized Jared's vulnerability, ensuring that my approach was handled with, the utmost care despite his, resistance to traditional intervention. The case highlighted significant limitations in agency capacity and the restraints of an outpatient setting when treating active unmedicated psychosis. Jared's needs were fundamentally mismatched with the agency's clinical scope. I mentioned it many times, but it should be stated again. We did not have the proper tools to be able to help Jared the way that he needed to be helped. Um, Acknowledge while the specific interventions were clinically unsuccessful in stabilizing Jared, the case provided a unique learning experience for me. So, when treating someone under psychosis in an outpatient setting that is unmedicated, I know some interventions can be very much, too much so soon. Maybe like, he wasn't ready for the role play. Maybe he wasn't ready to have things that challenged his thoughts in a way to where he might thought that I didn't believe what he was saying. Now, I didn't believe what he was saying, but I was trying to, at the same time, be on his side and just be there in a way where, I'm here for you. And I can understand that, not saying this to him directly, but in your reality, you are experiencing all this. This is very real for you. And I want to be there while you're going through that isn't enough for someone in his situation that needs external help. And what he thought he needed, outside, help with government or military, I can't provide that. All I can do is, give my, empathy and, try to, be that outlet for him. But even it just, that wasn't the case and just did not work. It demonstrated the importance of identifying a client that requires higher level of care, such as inpatient. So I definitely learned that from Jared that he needed much more than outpatient. So for lessons learned, regarding rapport building with delusional clients, recognizing the limits of therapeutic control. So me being the therapist and being there for him was not enough. I kind of already mentioned this, but it just did not help that we were there for two different reasons. Even after identifying goals and objectives, there was still, I think, an ulterior motive on Jared's side that made it kind of out of whack and imbalanced with our therapeutic alliance. But it will serve as professional wisdom for my future career as I see more patients or clients that are going through this kind of thing, especially if I see a client like this that's outside of agency capacity. So I did the best I could with him. Ultimately, it was a failure, but a very unique learning experience. And I wish the best for him, and I hope he gets the help he needs. So for the next part of this presentation, I'm going to go over ethics, diversity, and social justice and policy overview. So for my ethical dilemma case, I had a high-profile client, otherwise a celebrity, who was frequently featured on television, the internet, and other media. I faced an internal struggle regarding the illusion of familiarity with the client because I kind of felt like I knew him because I've seen him so many times. So that created conflict of interest and clinical objectivity. Um, in the beginning. There was a parasocial bias, and my clinical integrity was challenged because I could have steered me from providing professional clinical assessment and objective evaluation, and that would be ethically unfair to the client and his needs. And I was also worried in this ethical dilemma that I might accidentally blurt out that like I knew this client because he is a household name, and I was scared that I might have to accidentally kind of let out that I know this client by getting into conversations regarding him and not being able to exit it, or say something, just say something that'll mess me up to let people know like, oh, you're seeing this client right now, they're at Whistleblowers of America, for whatever reason. I know that. But for me, I don't want that to happen. So that's where the ethical dilemma lies. So for the discrepancy, in a non-clinical setting, I'd be super stoked and super happy to see this client. I'd want to, ask them about their work, how things are going. It'd be the highlight of my month. But for professional values, I have to maintain a critical mindset, professional boundaries, focus strictly on the client's monumental hardship rather than their public status, and manage being starstruck to ensure client receives a standard, unbiased level of care. And for ethical similarities, integrity, dignity, worth of a person, professional competence, the familiarity trap, and the clinical shift. Treating the client as an individual in the need of respect rather than a media spectacle is one thing. Actively suppressing the urge to intervene on bits and pieces of information, instead of letting the client self-disclose that. Like, I may know the stuff you're talking about, but I want to hear it from them and forget about my own reality of what I know about that situation if it is public news, right? So the impact of the ethical dilemma, it made me stumble. When I first saw this client, I did not know that this was the client I was seeing. I did not know it was a famous high profile client. When I was assigned this case, the agency didn't let me know or tell me. Not that's a fault to them, but when I saw them, face to face, in a virtual meeting, I was like, for 5 seconds, just going like, oh my goodness. But I had to pivot from that because I knew immediately that, this is, unacceptable. So I identified immediately the client's body language, their uncomfortable expression, realizing, their awareness that their own fame was making a barrier in this very moment. So to catch myself from that stumble, I just mitigated it with a direct and honest statement. I went something up along the lines of, I know, who you are, but, I don't actually know you. I want to have a fresh start, and, I want to hear things from your perspective, and, understand that I am very not well versed, and you are the expert in your own situation, and I want to hear from you, and I'm going to pretend like I have no idea what you're talking about or even who you are, and we're meeting for the first time. Wasn't those exact words, but I think that's, something along the lines of what I blurted out at the time once I realized I was droning for 5 seconds. Um, so it provided some normalization. The client response was positive to that. He seemed a lot more comfortable once I made that statement. So once, the role clarity was done, we kind of, got over that. Okay, you're a famous person. This is crazy. Instead it's more like, okay, you're a client. Why are you here with the Whistleblowers of America today? What can I do to help? What's the presenting problem, et cetera, et cetera. So my utilization of supervision for this ethical dilemma was, uh, it was good. My supervisor told me that it's very normal for people at Whistleblowers of America to meet their first high-profile client there, intern or not. She said I got to reinforce those boundaries, when it comes to treating the client because they want regular treatment most of the time and do not want to be viewed through the lens of frame. And that when it came to, like talking, like the fear of talking about it. Something that she harped on me about was that that's just something that you have to do always and always be prepared for. You have to always pretend like you have to be prepared to meet a famous client, and you always have to know that you just cannot talk about it. Like HIPAA, guidelines cannot say anything about it, no matter how you feel, even if you think like, oh, it's very possible I might do it. Just have to come to terms that this is your career and that is something you must do. So I took that to heart, and I think it took me a long way. So for specialized clinical strategies in this ethical dilemma, Heroic Care by Sheasley, it's kind of like you want to be the hero for this famous person or someone you really adore, so you want to come to them, hearing everything they say as truth, not really doing effective treatment on them this way because you're more just catering to them in a way that's not challenging at all. And something else that Hegblom mentions is unavoidable dual relationships. So it's something that you have to actively manage as a clinician. You just need to avoid media tabloids, and like all or other types of news. Because if they're in like, a new movie, like the news and an article, making a song, like you just need to avoid looking at those things while you are with the client because you want to remain kind of like ignorant and what is happening outside the world because you want to focus on the client's present. So you might know that they released a new song or made a new movie, but like they might want to tell you that. And not seeing those things will avoid that dual relationship, and you can really hear it from their perspective for the first time, authentically. So next, I'm going to transition to my human diversity social justice case. So for this client, they were neurodiverse with IDD. He was a 19-year-old male with non-severe autism. There's a social justice gap. Despite having a familial support system, the client faced a systemic lack of provider resources, and this hindered his access to independent living and essential daily guidance. His challenges were primarily centered on basic life skills and advanced communication, rather than debilitation, for not being able to do like things like make yourself a plate of food. His problems were a little bit more advanced. Um, so from this, I developed a shared, lived experience that made me connect with the client because I also have a learning disability. And when I was born, I was born stillborn. And the doctors told my parents when they resuscitated me that I was going to have low cognitive functioning and many developmental disabilities. So for me, like that could have been my life as, severely, disabled mentally, but that just wasn't the case. So I'm very thankful, but I can definitely understand, from a parent's perspective and from a client perspective, how scary that might be. So there was a lot of relational empathy that I had towards the client. And I had to navigate the privilege and difference, still, because while I could have had those things, I didn't. So I had to understand that life does look a lot different for both of us. And the clinical application of the social justice, the treatment focused on his right to self-determination, his willingness to tackle forward and difficult challenges to receive and achieve a higher quality of life. And by relating as equals with different levels of disability, I fostered an environment where the client was seen as for his potential rather than his diagnosis, because he had so much room to grow in a very positive way. It seemed like he could only, go up because he was seemingly doing fine, but just in these areas of his life he was trying to navigate, which was mainly the advanced communication. That's, something that can be grown through a numerous, amount of resources and treatment, which we'll get into in a sec. So for the countertransference piece of this case, there's initial clinical anxiety. Um, I thought there was going to be, some roadblocks, concerning the autism and IDD. But I felt a strong sense of duty that would motivated me to get past this anxiety to give them the highest standard of care that I could. Um, and I tried to I like look through the mirrored self, because I had my own experience, they had theirs, so it kind of like enabled a bridge. So it allowed me to kind of see a client struggle through the lens. Also, working with people with IDD and a case management job position I had also helped me see through a different lens. So I've worked with this population, a lot. Um, and then, obviously managing my biases. The potential bias regarding the client's lack of cognitive ability as a challenge to treatment. But I mitigated that by the core belief in human potential, and I shifted focus into internal motivation, willingness to work, viewing this as superior to any cognitive limitation that the client might have. Um, and as for therapeutic strength, I saw a lot of assets he had, mainly focusing on the strengths, which was his willingness to try and learn. So the impact on the client from the social justice speech piece is the peer gap. So while he wasn't explicitly bullied, he felt perpetually ostracized by his non-disabled peers. It's created a social barrier that discourages his natural extroversion, has an impact on his mental health, discrepancy between his desire for connection and his lack of social circles, meaning like friends, girlfriends. It led to some depressive symptoms, and he loves to be extroverted and talk with people he really likes. He was very extroverted with me, so you know, him being kind of having that ostracization is really holding back, a lot of his social personality. And also the coddling trap and systemic dependency. So he was coddled by a circle of support. His close circle of support, while, very supportive and helpful for him, they assume he was incapable of tasks before he even attempts to try them. This has an impact on his autonomy because it's overprotection and it erodes his confidence and sense of agency, holding him back from age-appropriate development. So there's many things that he never tried because he was told there's no use. It probably, you won't succeed anyway. So never got that opportunity. This comes with, making friends and doing all sorts of things. So from a social justice lens, this is a very common issue in the IDD community, and it can inadvertently become a barrier to the fundamental human right of self-determination, which is that coddling aspect from the circle of support. So the intervention strategy that we used is role play and empowerment and social skills training. And I used a multidisciplinary and strengths-based approach, utilizing like DBT mental exercises and of the liking. And I tried to use justice through autonomy by validating his feelings and addressing the social injustice of the isolation, the ostracization he was having. And in our meetings, I try to give him as much free room to be himself and explain himself as much as possible and give him as many opportunities to try and succeed or try and fail to kind of reclaim that and give him some sense of confidence and empowerment that his, support system isn't currently getting him. So for advocacy and potential solution, addressing the social barriers, like he wasn't allowed to have technology because someone could harm him. A lot of people had high distrust of outsiders, being a circle of support. Um, they created a bubble that well-intentioned, it limited the client's ability to communicate and use skills in real-world settings, by separating and then also not letting him try certain things. So to advocate in that sense, I looked up a IDD specific social club, and through the approval of all parties, the client was able to go to this and made friends and met people with similar, um, disabilities that he does. And they do activities like structured activities like bowling, art, park games it's a safe outlet that's supervised by someone who manages the club, and it helps them create meaningful relationships and friendships. And the potential solution is, giving these clients dignity of risks and understanding the value of failure because they are learning lessons and they're within, reason. You can supervise, someone with IDD doing something new and helping them to, you know, try something, mistake or not. You'll be there to catch them when they're down. This way they'll be able to, try new things and not be so, like they can do what they got to do, and it creates that autonomy. So I love that case. But moving on to the social policy case, I had a client who was experiencing workplace retaliation. They were subject to active harassment and demotion and working conditions such as moving from a standard office to a confined shoebox. After whistleblowing, this had ADA implications because it triggered new mental health challenges for this client, specifically claustrophobia and heightened anxiety. So with this client, the social policy case that was effective to them was the WPA, the Whistleblower Protection Act, because they worked in a certain part of government that was protected by this act. So the covered individual was them. The protected disclosure was, when they were whistleblowing, and prohibited personal actions were what the employer was doing and retaliating to the client against. So with this, I did some case management and advocacy. So we shifted towards a policy-informed approach and kind of wanted to help the client pursue legal action because they were protected under the WPA. So systemic solutions would be pursuing the court case and get their original working conditions back and compensation for their mental anguish caused by the retaliation. And this case demonstrates exactly what the Whistleblowers of America is about. We help those that are whistleblowing and going through these tough times, because they are vulnerable and subject to a lot of scrutiny. So for this client, I use narrative therapy and solution focused therapy. Narrative therapy for making sense of their experience, their workplace harassment, and by externalizing the problem. SFT to focus on what we could do here and now, which was, try to find legal counsel, legal help, get a case underway to help them, in this respect. As a tool that we use for people that use this policy is, the Department of Homeland Security versus McLean case. It's a landmark case where an airline pilot successfully fought retaliation after exposing TSA, public safety failures, and had a lot of clinical utility as he won it after an 8-year-long battle. These battles are usually very long, but they can be worth it or not worth it depending on, who the client is or the whistleblower is. So the intervention results, the clinical outcomes were healing the moral injury. So it was restructuring through narrative therapy that they did the right thing, even though they were being punished through it for their work, and resolving that moral conflict identified with moral injury because, it's they did the right thing, they're speaking out, they're getting punished for it, but that's not exactly in their control. And yeah, there was, focusing on the short-term success. What we could do to help this client at the time was, empower and stabilize her, but I won't be able to see the final court verdict for in the long term, which is kind of sad because I do wish the best for her. And, I utilized expertise of my supervisor, who herself is a whistleblower. So she always knows a lot going into these retaliation cases. And I always debriefed with her after, doing, sessions with this client. And she would tell me about her, high level advocacy work and what they were doing, to help provide the WPA more protection or more influence in the higher courts. So I would propose an expansion on the WPA. for small businesses to trillion-dollar companies, so everyone is covered, not just government branches and people working for them. So this would or this would expand the scope of protection so that all people can speak out, and it would create a much larger scope of, what we see in unethical and illegal practices within, companies. I feel like a lot more whistleblowers will speak out and talk about their case and bridge the information gap so that way when a crisis occurs and someone sees something, they know that they're protected and they can, immediately act on it without so much fear because they're protected under the WPA. So in conclusion, for this piece, as a learning reflection, the WPA, WOA was a fantastic place to learn and experience all these topics. The ethical dilemma was crucial in understanding how to approach and treat high-profile clients. The HDSJ case was a success case that made the clinician want to work with the vulnerable population and really spoke about, the injustices going on with that specific vulnerable population of people, and I care very deeply about it now. The social policy experience made me realize, even in a small niche of social policy in relation to other bigger ones, more advocacy and awareness is necessary for meaningful changes. And I feel prepared for the field, but I will embrace the opportunities for more learning and enlightening experiences as I go on in my career. So thank you so much for listening to my capstone case and my reflection piece. Um, and I hope you all have a great day. Thank you.